Welcome to another outstanding City Club Forum. My name is Susan Kelly, and I'm the president of the club. Today we focus on mistakes in medicine, disclosure and improvement with Dr. Susan Tolle, professor of medicine and director of the Center for Ethics in Healthcare at OHSU, and Dr. Christine Cassel, dean of School of Medicine at OHSU. Join us for next week on Friday, September 20th. Join us for a program entitled Civil Liberties Challenges in the 21st Century, featuring Nadine Strawson, National President of the American Civil Liberties Union and a professor at the New York School of Law, and that is here at the Multnomah Athletic Club. Please pay particular attention to our bulletins in the coming weeks. They will contain several board-approved resolutions on ballot measures that will be on the November ballot. These resolutions are based on related research reports and club positions on these issues. In addition, we have 4 committees busily studying 5 of the measures that will be on that ballot. These reports will be coming to you for debate and voting in the next several weeks. On those days, we will begin the Friday forums at 12 o'clock in order to provide sufficient time for the report and for the program speaker. Please also note that we have started our annual fundraising campaign this week. Whether you are a club member or a friend who benefits from what this amazing organization offers the community, please fill out the pledge card in the bulletin or that you will find on your tables, the orange cards. Our goal this year is $100,000, and we really, really must achieve that goal. Anyone interested in obtaining a video or audio tape of this program or other City Club programs may do so through calling the office. Call Suzanne at our office. The videotapes are $20 each and the audio are $10. Our board host, seated at the head table, is Corleen Kraft. She is a member of the Board of Governors and a realtor with the Hassan Company. She will have the privilege of asking the first question of our speakers. Following Corleen's question, we will open the program to questions from City Club members in the audience. Please line up behind the microphone even before Corleen is finished so that we have time for as many questions as possible. Identify yourself as a member of City Club and ask your question in 30 seconds or less. Our broadcast of City Club programs this quarter is made possible in part by corporate underwriting from Kaiser Permanente, Wells Fargo Bank, and Zimmer Gunsel Frasca Architects. We are very grateful for their support. Our speakers today, Susan Tolle, the first to my left, is an MD. She received her bachelor's degree from Lewis and Clark College. She earned her Doctor of Medicine degree from Oregon Health and OHSU. Her postdoctoral training followed at the University of California, San Diego, with a residency and chief residency in internal medicine. She returned to join the faculty at OHSU in 1981, and in 1988 she pursued a fellowship in clinical and medical ethics at the University of Chicago. Dr. Tolle returned in 1989 to the OHSU to become the director of the Center for Ethics in Healthcare. The center collaborates with health professionals from many different agencies and organizations to explore a wide range of issues in healthcare ethics. The center is nationally known for its work in end-of-life care. In the early 1990s, Dr. Tolle spoke before the City Club about her research in this area, so welcome back. Dr. Tolle serves as chair of the National Advisory Committee for the Robert Wood Johnson Foundation program called Community State Partners in End-of-Life Care. She has previously served as a member of the Ethics Committee of the American College of Physicians American Society for Internal Medicine and chairs the Planning Committee for the Kinsman Conference Series that brings statewide leaders in healthcare ethics together on a yearly basis to explore such issues as disclosure and medical mistakes. Dr. Christine Cassel received her bachelor's degree from the University of Chicago. She then earned her Doctor of Medicine degree from University of Massachusetts Medical School. Her postdoctoral training followed at Children's Hospital of San Francisco, the University of California in San Francisco, Oregon Health and Science University, and Portland Veterans Affairs Medical Center. Dr. Cassel is the OHSU School of Medicine's 13th dean and the first woman to hold that position. She comes to OHSU from Mount Sinai School of Medicine in New York City, where she was professor and chairwoman of the Department of Geriatrics. She also directed the Geriatric Research, Education, and Clinical Center at the Bronx Veterans Affairs Medical Center. As a member of the Institute of Medicine of the National Academy of Sciences, Dean Cassel was the first woman president of the American College of Physicians, American Society of Internal Medicine, and is the past chairman of the American Board of Internal Medicine. She is recognized for her expertise in geriatric health policy and medical ethics. She chairs the board of the Greenwall Foundation, which supports work in bioethics, and is president-elect of the American Federation of Aging Research. I'm very pleased to introduce such important and serious speakers today about an issue that is very sensitive, but in light of all of the, as I was just saying to Susan, the safety issues we've experienced in this last year, our personal safety, our spiritual safety, we don't feel safe with the corporate chaos out there. We don't feel safe even with some of the choices our government is making. So this is a pretty serious safety issue, and thank you both.
It's wonderful to be back and to be with a group that takes on very tough, very serious issues. Today we're going to talk about medical mistakes, and we're going to talk about it in two ways. First, we're going to talk about disclosure, an area near and dear to my heart and those who work in the Center for Ethics in Healthcare. How truthful should we be, and with whom should we be truthful? What is our history in that area? What is the issue related to individuals and change and mistakes? Then we'll turn to Dean Cassel, who will talk much more about areas of improvement and the broader issues that relate to systems change. And how can the two complement one another? We're part of a whole movement across the country. Many here have been working on this issue for some time. There's much work to be done, and we can further link arms in making change. I think it's easiest to make this come alive by telling a patient's story, weaving that story through our history, and helping us see what is at the individual level and what is at the systems level. The story I share with you comes from a Boston hospital and is several years old. A 52-year-old man has had asthma for some time. Periodically, he has a lot more trouble breathing and is admitted for short periods of the time to the hospital to help with his breathing episodes. He has one other medical problem, it's diabetes, and he takes a small amount of insulin every day, 10 units. He's otherwise in good health. During the night, he has a terrible time breathing and is admitted early in the morning for his asthma. An internal medicine resident evaluates him and writes his admitting orders. Already he's beginning to improve with the treatments he received in the emergency room. His breathing is getting a little freer. She writes orders for further treatments for his breathing and orders his 10 units of insulin to be given that morning. She goes on to see her next patient and is called urgently in the afternoon. He's unresponsive. His blood sugar is 30. 30 is very low. It's obviously why he's unresponsive. He's quickly treated with IV glucose, sugar, and raising his blood sugar and transferred to the intensive care unit. She is asked to present what happened at what is called Morbidity and Mortality Conference. That is where doctors in training share things that have gone other than we wish them to have, whether or not it's due to a mistake, with fellow doctors to see what can be done differently. That conference, as I remember it as a young doctor and a doctor in training, is certainly not anything you ever wanted to be the presenter at. And it really was a sense of disclosing a shortcoming, a failure to find something, or an outcome you couldn't explain, but it was adverse. It's the beginning, though, of clear shame associated with mistakes. It's an important part of medicine's history. When she shared her mistake with the group, what she explained was that she had written the 10 units as 10 and a U, and they passed around the chart record, but the U was sort of closed and the word unit not written out. And the patient got 100 units of insulin. For those of you in medicine, you realize that that's far more than most anyone would need on any occasion. And obviously the reason his blood sugar was low, since it's a long-acting insulin, it required overnight IVs to continue to correct the insulin being absorbed and the repeated low blood sugars that would have otherwise resulted, which is why he needed to be in the intensive care unit overnight. At that session, there was talk of clearer handwriting. There was talk about checking sooner in the afternoon on blood sugar readings. There was no talk about how one discloses a mistake. And there was no talk regarding the systems issues that might have been involved. Back several years, that just was not how the teaching took place. The next morning, he is well enough to be transferred out of the intensive care unit and back to her ward service. She calls on him, listens to his lungs. His lungs are improving just as planned. This had no impact on the treatment of his asthma, and he's continuing to improve. He's very tired from the low blood sugar, but he did not have some of the complications that can occur, like seizures or brain damage. And other than being tired, his blood sugar is now normal, and he's back on his 10 units of insulin a day. He asks her what happened. And she says, "You had a low blood sugar, and you were treated overnight in the intensive care unit. Your blood sugar is normal now, and your breathing is improving, and it looks like you'll be able to be discharged as planned tomorrow." Enough? The truth? Everything she has said is actually true. He did have a low blood sugar. It is normal now. His breathing is improving, and he can go home tomorrow. But there are some things she didn't share that you all now know. Should those be shared? And with whom? That's really the focus of our work in the Ethics Center, is that whole issue around truth-telling, disclosure, and some of the issues of disclosure are critical to our success in the systems area. When we are ashamed, when we hide what we have done, when we don't tell patients because perhaps they will respect us less, perhaps they will be angry, perhaps they will sue us, then trust can be eroded in the doctor-patient relationship. Some say, well, trust will be eroded when you acknowledge a mistake. And others really talk openly about acknowledging an error and describing an error may leave you more open to litigation. But there's another place we need to think about disclosing, and that's to the health system itself. To be sure that system errors, including near misses, are reported in such a way that we can keep track of them, identify them, prevent them in the future. So disclosure, while you might think very quickly, especially as the way I've shared this story, is to the patient, I would argue there's another additional very important disclosure to take place. Many of us are working hard to bring about change. One person who has joined us today is Dr. Jeff Gordon, who is coming back to the university after having been on the East Coast for 5 years at the Bayer Institute to help us devise new educational curriculum about medical mistakes and other tough issues. 16 years ago, Dr. Gordon and I developed curriculum about disclosure to families when patients die, and began the whole process of much more open communication in doctors and patients at the end of life and end-of-life planning. It's one aspect of the many changes that have taken place in the whole culture of medicine at the end of life. We're talking about a profound cultural change, and we do need more teaching about exactly how to do these tough things. Jeff and I and others are fortunate to have many willing partners in the greater Portland area. People like Barry Edgner and the Foundation for Medical Excellence, and colleagues at other institutions and working in the area of safety. Dean Cassel will talk some about those. We're also very fortunate to have partners who've supported our work, and those of you who are here know who you are, and thank you very much. Let's talk about what the future might look like and write a different story for this young woman moving the time clock forward after the new curriculum. She goes into the room that morning. Her patient has just come back to the ward, and he says, "What happened?" And this time she says, "You had a low blood sugar. It's because you got 100 units of insulin instead of 10. That meant you needed to stay all night in the intensive care unit for treatment and close observation. That long-acting unit insulin is now out of your blood system, and your blood sugar's normal, and you're back on your regular dose. It is why you're very tired. Also, I am working with other people from the hospital to understand what went wrong in our system and to make sure it doesn't happen to you or anyone else again. I've also talked with our administration regarding the bill, and you will not be billed for your intensive care unit stay. I'm sorry this happened to you, and I do know you're tireder today because of the insulin reaction. Do you have any questions that I might answer?" That is a very different message from the first one. Is she more likely to be sued? Is the patient going to trust her more or less? She also adds, "I've also written an order that whenever you are given your insulin, that you are to be allowed to check the dose before it's given." Does this patient know what the right dose is, having given his own dose every day for several years? Would he know the difference between 10 and 100 units? Can we involve patients more as partners when they're capable in also helping us double check? We need to look at this at a systems level as well. This is in collaboration with the work of the Ethics Center, but far beyond it, but an area that Dean Cassel brings incredible wisdom and experience, locally and nationally. Not only does she have all the achievements that were listed in her introduction, but she serves and has served on multiple Institute of Medicine committees nationally exploring these issues, including the one called "To Err is Human," which is the report 2 years ago that outlined the mistakes in medicine that made so much of front-page news about the frequency of errors and the problems in our healthcare system. She also served on the committee that looked at safety and quality, called the Quality Chasm. She brings a national perspective about this level that's more than just the doctor and the individual patient. This is a whole lot more than this young doctor learning to change her handwriting. Where was the pharmacist with this dose of 100 units? Where was the nurse with this dose that is so high it should have raised everyone's eyebrows? Where are the checks and balances in our system that keep a handwriting error from becoming a potentially lethal mistake? That's where our systems need to come in, and we are so fortunate as a state and an institution to have Dean Cassel back. Thank you.
Thank you, Susan, and thanks everyone for the welcome. I do feel like I've been set up a little bit. Now we have this terrible problem, and I'm going to tell you the answer. Well, it was interesting, having been involved in the quality movement, as we're now calling it nationally, for the last 5 years. It's been a very interesting experience to witness the growth of public concern, public awareness, and public engagement with this issue, and that's one of the reasons why I'm so pleased to be with you here today. The first report that came out from the Institute of Medicine, as Susan said, was the one called "To Err is Human." I was in New York at that time, and because of that, was besieged by the media about this report. The main sort of headline from it was that there was somewhere between 42 and 98,000 preventable deaths a year that could be attributed to mistakes in medicine. And some of the people who work in the field had generated the analogy that that would be the same as 2 to 3 747 planes crashing every week. Now you do the math, figure out if that's right. But the fact is that the airline industry, when one plane goes down from an accident or from some kind of mechanical error, goes into a huge investigation mode. There's a lot of public attention to it. And in medicine, if it's anything close to that, we should certainly have some of the same reactions. And indeed, the airline industry has turned out to be an industry that we've looked to as we try to make healthcare safer. And there are a number of important lessons from that industry, which I'll mention to you in a moment. But I think that it's also important not to overreact to this kind of data. Some people have questioned exactly how these numbers were generated. They were projections based on a couple of studies, one in New York and then another one that combined Utah and Colorado that did reviews of patient charts. But you know, it almost doesn't matter what the exact numbers are. What's really important is that we all know that mistakes can happen in all aspects of our lives, and that modern medicine is so complex, so technical, and involves so many different people interacting around very complex issues that mistakes are bound to happen. So we ought to expect that, and we ought to develop systems that can reduce those errors and continually improve our trust in the systems of care. Now, when I got a call actually at 5 o'clock the morning that the report was released from a number of different New York-based media stations, I went around in a car from one to another doing these shows, and I remember talking to Katie Couric about this, and the thing I learned is that when there's an issue like this, the public doesn't want to hear it's a systems problem, we just need to fix the system. They want to know, how do we get the bad doctors out? How do we find out the nurses who are making these mistakes? And that, of course, is exactly, as Susan mentioned, the wrong message, because while we know there are probably a few bad apples in any system, we have systems in place at the state level to deal with that, and that's not what is generating these kinds of mistakes. It is, in fact, much more of a systems issue, but that's harder to understand, harder to talk about, and requires more sophisticated thinking. And to that end, the Institute of Medicine has generated now 4 additional reports and is continuing to work in this area. The second one, actually, in some ways is much more important. It's called Crossing the Quality Chasm. And that report points out that it's not just about errors, but about all aspects of this tremendously expensive and growing healthcare system that we have real problems in delivering what it is that patients really ought to be able to expect in terms of safety, efficacy, efficiency, patient-centeredness, timeliness, and equitable healthcare. We could do better on all of those scores. And when we originally finished this and were trying to decide a title for the book, Dr. David Lawrence, who was on the committee and is, as you know, one of Oregon's very heroic and successful citizens, said, well, we were talking about the gap in the quality of care. He said, it's not a gap, it's a chasm. It's a huge chasm. And so he's actually the one who's responsible for naming that report, Crossing the Quality Chasm, and really throwing out for us the challenge for doing that. Now, there also have been 2 subsequent reports, one of which outlines for the nation targets for improving quality and is going to be generating, starting next year, national reports of quality of care in certain areas that then can generate new targets and goals for us to all together try to improve healthcare. The next one was one that I was directly involved in, involving health professions education, looking not just at medical education, but at education of the whole range of people involved in healthcare delivery, and how the education of those individuals can really be changed to try to improve the quality of care. So the issue has many different dimensions, and I want to just sort of outline, from my perspective as an educator, what I think some of the important advances we've already made and directions in the future will be. The first is to just remind you of the lessons that we've learned from the aviation industry. The first thing is that pilots are very carefully scrutinized, very carefully accountable and trained. They actually have to go through a simulation exercise every 6 months in order to maintain their license as a commercial pilot. Doctors have to take a written test every 7 to 10 years that tells you what they know about medicine, but it doesn't tell you about their skills or proficiencies in doing certain kinds of procedures. Maybe we should be having a more engaged process of keeping not just doctors, but nurses and others involved in monitoring and improving their skills. Second thing from the airline industry is simulation. We don't have to have a plane almost crash in order to teach a pilot how to deal with what happens when one of the engines goes down. We have simulators, which can be very realistic and very good training for all those kinds of unpredictable events. Increasingly in medicine, we're doing the same thing. We don't want to have people have the first time they practice in a situation be with a real patient in a real crisis. We want to be able to have the students and the residents practice on models and in computer simulated experiences. Increasingly, the technology is available for us to do that. And there also are standardized patients who can act as though they're experiencing a certain kind of patient need or experience or communication problem, and can really help give very useful and productive feedback to the students and trainees. And then lastly, reporting. The airline industry has a mandatory reporting system where they report not only actual errors, but almost errors, or what are called near misses. And actually, when a near miss occurs, when something goes wrong in the cockpit, they all the next day get together with a team of people and dissect everything that happened and figure out ways that it wouldn't happen again. And a big part of that is training the entire team to feel comfortable criticizing each other, so that just because the captain is the big guy and the head of the team, the flight engineer or the second officer or even the flight attendant might say, "Are you sure you want to do that? Is that really the right thing to do?" And they practice actually challenging each other in that setting, so that they don't let the hierarchy get in the way of somebody who might be lower down in the hierarchy, understanding that maybe something's gone wrong and bringing it to the attention of the others. Now, those are all, I think, very important lessons that we can learn and apply to medicine. And in fact, we have a good model of that within one of the specialties of medicine, anesthesia. Anesthesia was a specialty that had lots of problems with high malpractice rates and high error rates. It's a very high-risk situation, of course, when you're putting someone to sleep for major surgery. And they took it on themselves about 10 years ago to change how things happen in the operating room, to make it, as they say, hard to do the wrong thing and easy to do the right thing, putting redundant systems in place on the monitoring equipment, making the medications just unit doses, so no one could ever get that 100 units of insulin that Susan just described, because it doesn't come packaged that way, having color-coded labels on the medication so you couldn't mistake one medication for another, which was sometimes an error that did occur. And in fact, they were so successful in doing this that their insurance rates dropped significantly. And I think it's a really sort of useful lesson for the rest of healthcare about how some colleagues of ours, even without the scrutiny of the public eye that the IOM reports have generated, really did, on their own initiative, make some changes and improve things. So what can we do now with the rest of medicine? Well, the culture of medicine is changing, and it's changing in response to this whole challenge about public accountability and quality. The components are very similar to what I just described in the airline industry. Much more emphasis on teams, understanding that doesn't matter how smart or how good a physician is, that a physician alone these days can rarely really deliver health care. It's just too complicated for that. You have to have nurses, you have to have social workers, you have to have pharmacists, you have to have technicians, and you have to have multiple different medical specialties as well. So importantly, we have to have that kind of communication loop, as in the cockpit, where people are not afraid to raise questions, to challenge each other, and to say, are we sure we're doing the right thing with this patient? That means there also has to be good communication systems to allow that to happen. A sense of openness, a sense of wanting to know if I almost made a mistake so that I can prevent it from happening again. Not that kind of shame culture that you heard from Dr. Tolle. In order to really make this work, we also need better information systems. That's what the airlines have, that's what the anesthesia people generated, and that's what the rest of us need. And that requires a lot more technology, computer systems, et cetera, so that we can actually understand what's happening with our patients and get the information back on a timely basis so that we can improve it as we go along. Now, that's a principle that comes actually from a number of different other industries. The quality improvement principle. It's been very well demonstrated in manufacturing, for example, that if you just give people feedback about the quality of what they're doing and maybe the rate of certain kinds of mistakes that they make on the assembly line or in any other kind of setting, that they'll improve. They improve because it's human nature, if you know what you're doing wrong, to want to get it right the next time. And in medicine, we haven't had those kind of feedback systems. We've tried to, especially in the physician world, tell physicians that they should get everything right every time and that they should know everything. Well, going from a time a decade ago when there were maybe a few hundred publications of randomized trials and good medical evidence a year to a time now where there are tens of thousands of such articles a year, it's impossible for any physician, no matter how brilliant and how hardworking, to really have all that information at his or her fingertips. So we need to use computer technology and information systems to both provide the information when it's needed, and also to give you feedback about how you're doing. If you have a busy practice and you have a lot of patients who have high blood pressure, you should get a report every month that tells you how is the blood pressure doing on every single one of your patients, so that you have a way of knowing that without waiting for them to come in to the office in a crisis. Those things are all possible and are all within our reach. Within the educational environment, we're fortunate now that we're able to take part in this change of culture, because you can't educate them, no matter how good your curriculum is for the medical students or the residents, if they aren't actually witnessing this kind of thing in the clinical setting where their teachers, the clinical faculty, are practicing medicine, involved in teams, involved in quality improvement, using feedback and looking critically at their own shortcomings, then all of the teaching is useless, because where the students really learn is where the clinical care happens. And so the convergence of these two things now, I think, is a great advantage for us. I would also mention two other things. One is the simulation technology. We now have at OHSU, a major new center growing in simulated patient situations of all kinds, in which the nursing school and the medical school are collaborating. We're also going to involve our colleagues in the dental school in developing this technology. We've got 3 patient simulators now, and we'll probably be getting more. Surgeons especially, you can imagine, are benefiting enormously from this simulator technology as they begin to get practice, not for the first time on the patient, but in a simulated situation. So there's enormous advantages that technology is allowing us in that area. The last thing that's happened is, improvement happens with a carrot and with a stick. And the carrots are that we all want to do the right thing. That's why we went into healthcare. We're fundamentally motivated to try to take care of people and are gratified by the response that we get from patients and families. So that motivation is there, and that's a very strong one. But we also are very, I think, legitimately scrutinized by the public and held to certain accountability standards. There is an organization, the Accreditation Council for Graduate Medical Education, which accredits training programs for every specialty in medicine. So if you are not an accredited program, you're not going to get anybody coming to train in your program. So it's a very high stakes thing to be accredited. This organization, the ACGME, starting this year, is requiring every specialty to demonstrate competencies of their graduates, not just that they can pass a written test, but that they can actually perform certain kinds of practice competencies. Now, most of them are things you might expect: medical knowledge, patient communication, which is really important, clinical practice. But the 2 new ones, which are really part of this new chapter in medicine, are systems-based thinking and practice-based quality improvement. Now, those didn't used to be part of our curriculum at all, and we're now being required by the accrediting agencies to demonstrate that we can evaluate how well our trainees do at thinking about how to solve problems in a system and using outcomes data to improve their own practice. So I think this has been a major breakthrough, and that the council that made this happen has worked over the last 5 years with the specialties to find something that was workable, and that this will really add, I think, to our ability to make this progress. So we welcome the involvement of communities and of patients, families, and other experts in education in thinking how we can continue to improve the quality of healthcare. Thank you.
Doctors, thank you so much. It's a privilege that we are able, as a City Club of Portland, to get persons on our podium of this caliber, so I want to thank them very much. It's enormously gratifying to know that, indeed, these outcomes are being followed carefully and that new programs and systems are being designed to help alleviate some of the problems that terrified us so much when we had that report a few years ago. What I'm wondering, though, is that I've noticed over the past few years, and I think it's primarily because of the cost of medical care, that while you're talking about training for the higher level, the higher echelon, I see many practitioners being aided by people who are not RNs, for example. So that the quality of care, I'm wondering if the education will be extended to that group. I'm wondering also, with full disclosure that you've mentioned, how that is affecting malpractice premiums, if at all, whether there are models around the country of hospitals and organizations that have implemented this kind of training and education, and how that's affected the outcomes.
I'll do the first part, which is reaching out to other care providers throughout Oregon. We have started a statewide outreach program to nursing homes throughout Oregon. Dr. Susan Hickman, who's here with us, is actually coordinating that activity, and we're going around to La Grande, Coos Bay, Bend everywhere we can get to around the state with a 3-year grant from the Arthur Vining Davis Foundation from Florida to provide education focused on suffering and communication. But we'll be incorporating each year, because this is a 3-year grant, new curriculum for the leaders in the long-term care facilities to take back to their line staff. So we do understand that it isn't just an OHSU model. Some of the highest level curriculum, though, often has to be developed by the people who are your mentors, because otherwise it just doesn't take hold. Many people have thought to change a culture, you start and train a new generation. But if those they admire most don't believe it, don't support it, don't endorse it, your efforts won't carry very far. You need both. You need to come and meet in the middle. But we do have some exciting outreach reaching out to long-term care as well.
And I would just add, Carlene, related to that question, that we're focusing on the educational institutions, the medical schools, the teaching hospitals, but there is a great deal of attention to these areas in continuing medical education, so that physicians who are already in practice, who may not be in a training hospital, are hearing this message as well. But then it's up to them and the people in practice to bring the other health professionals who are involved in care into this patient-centered approach and use whatever kinds of teamwork experiences are possible to do that. I think a lot of enlightened healthcare administrators are very interested in this these days, but you're absolutely right. It's not enough to just have a couple of people, and if not everyone is on the same page about it. Let me just address your issue about malpractice. When the report to Errare Human came out, I testified at a hearing in Congress about it, related to one of our major recommendations, which was that there be mandatory reporting from hospitals about medical errors. As you know, that has not been enacted in legislation, and I think probably will not be. And the fear was exactly what you said, that there wasn't any protection for people against the discoverability of this information and its use in liability settings, and the ability to sort of have any that exposure is a chilling effect on this quality improvement model. And while on the one hand you want to make sure that you're having people able to exercise their rights within our society, on the other hand, if you really seriously want people to disclose near misses and make things better, you have to create some kind of a protected environment in which this information can be shared. Now, the quality improvement efforts from the Joint Commission that are conducted by every hospital's medical board are protected in that way, and so there are ways that actually some of this information can be used in that way. But every single national meeting that talks about this, the issue of some kind of change in how we handle medical malpractice continues to come up. So I think that we may see some changes in that area. I'm on a new committee now that's looking at some demonstration projects in which the whole malpractice system is restructured to allow quality improvement.
Okay, keeping in mind that malpractice issue, I'm Cy Cornbrook, City Club member and member of the Healthcare Issue Committee, that's the way it is now. Have you given any consideration to a non-punitive, anonymous system of collecting the least of the statistics on the various problems that have occurred with a view to in areas where you can, changing the systems? And if not, why not?
There are some very interesting models out there that are sort of like no-fault insurance, sort of workers' comp kind of model, and the legal experts in this field, which I'm not, but people whose opinions I respect greatly, believe that actually those kinds of models would actually compensate more people correctly for harms that have been done than the current system, which ends up generating very big rewards for very few people. And most people who've actually had some kind of injury don't ever go to court, and if they are, they may win or not. So the system we have is a very expensive one, and it doesn't really get to the problem. And so there are discussions at the national level and also at the state level. There's been a demonstration project in Utah and Colorado about exactly this, which is why we got that data from those two states. It's going to take some leadership from the legal community, obviously, not just from the healthcare community, to make that happen.
Thank you. I'm Dr. Edward Press, City Club member and former state health officer and CEO of the original State Board of Health. Dr. Cassels has already answered part of my question in advance, but the question relates to if we're going to carry through with Dr. Tolle's and your suggestion that when you make a mistake, admit it, tell it to the patient, then the patient is liable to sue the nurse who said 100 instead of 10 units. And so you got a liability problem. And should the current mechanism for liability insurance be extended, and if so, who's going to pay for it, and should the people like the doctors and nurses and pharmacists participate in the payment? That's the question about increased liability insurance, and if so, who's going to pay for it?
Let me comment on one aspect of that, which is that while nothing is ever 100% sure in this life, legal advisors always tell us that the best malpractice insurance is to have a good relationship with your patient. And Susan's point, I believe, is that it's all about trust. And if the way in which we handle this kind of disclosure can increase trust, it may actually lead to fewer lawsuits. Doesn't mean none. It doesn't mean that there's any sort of perfect protection there. But there is some reason to believe that the trust factor plays a large role in that kind of protection. The other issue you raised, which is a kind of enterprise liability issue, is I think another of the interesting models that people have talked about, where it's not just the doctor who gets sued or the nurse, but that there's some kind of corporate liability because of this systems issue that we're talking about. If we really believe what we're saying, which is that it isn't that you personally made the mistake, but that the system needed to be improved, then the system perhaps ought to be held liable. Physicians, organized medicine has not been very supportive of that, interestingly enough. I think believing that it's the doctors, who are accountable, but revisiting that issue now, we may find some different attitudes about that. It means, though, that we do have to take seriously our responsibility within the system to help work and improve it, and to work with the other healthcare professionals there.
Susan, Dr. Tolle, do you have any comments to add?
The Lexington VA has led the way in many ways in a very clear policy of disclosure, very much like the one I outlined. And they've been compared to other VAs, and their suits are no higher. So there is some preliminary information that says that it may, with very much openness and trust, not necessarily increase suit. But there are those who dispute that. It's hotly contested.
Thank you both.
Dr. Ralph Crawshaw. I'm a City Club member, and I want to start out by thanking both of you, the speakers, for being leaders in such a commendable effort. We've heard a lot today about carrots, not much about sticks. The whole business of collecting bad apples in this state is delegated to the Board of Medical Examiners. Let me ask you, in your efforts, how closely do you have a supporting relationship with the Board of Medical Examiners? How much is there a coordinated systems approach that goes from the carrot to the stick? Thank you.
That's a very good question, Dr. Crawshaw. As I'm sure you know, the system of state boards of medical examiners or licensing boards is very much a state-run set of organizations. There is a national federation of state boards, and Dr. James Thompson, who's the head of that, is very committed to this area of quality improvement and is doing what he can to make a national effort out of this. But legally, the way the structures are run, it's very much a state-by-state entity. So I think it's up to each of us with our medical associations and our nursing associations and others to work with the boards at the state level and to really work within that rubric. Having said that, you need some creativity because you don't want to go too far down the road of blaming the individual practitioner when a mistake happens, if in fact this actually is a moment for quality improvement and not a moment of a real serious problem with competence within the profession. So I think that I know that medical boards around the country are educating themselves around this and trying to develop the appropriate balance for that kind of approach. I don't know, Susan, whether you have experience here with that.
Well, and there are a couple of other sticks. I mean, we've heard that accreditation groups are placing strong sticks on hospitals regarding issues related to accreditation and quality checks. And certainly our last site visit with JCHO showed a lot more focus in the area of safety. So there are sticks out there. There are also sticks regarding education that we heard about. The issue is both where does the medical board fit and where does peer review fit at another level. I think they are related when you're talking about performance and individual healthcare providers. And the issue is one, again, of protections in reporting as well. There are certain fearfulness at times in reporting when that needs to happen. There's also an issue in ethics that we need to teach about, just like the issues in disclosure about our own mistakes, is being sure that we take the personal responsibility to deal with an impaired colleague when that's the case.
Bill Savage, member. Dr. Cassel, you talked about the airline industry as maybe a model to some extent for quality. One of the things they're very strict about is time. Pilots cannot fly more than a certain number of hours, and so you can guess where this is going. So residents work, unless things have changed in the last few weeks, very long hours, and sometimes physicians do too, and they're making life and death decisions after no sleep for a couple days.
Absolutely right, and you raise a very important issue. And here's another place where the ACGME has just this year dealt a very strong blow, depending on where you stand, in favor of quality of care as well as quality of education, by limiting the number of hours that residents work every week to 80 hours. And now people laugh, but let me tell you, that's a real reduction in many specialties from what has been the norm. I know when I was a resident, it would, we all sort of worked. I think it was about 100 hours a week, and in surgical specialties probably more than that. And of course, that's a problem. All of us old people are saying, "Well, we did it, so why can't you?" But there is some data suggesting people do make more mistakes when they're tired. And surprise, we have empirical evidence about this.
The audience seems not surprised, Dr. Cassel.
So I actually think it's a step in the right direction. It's going to cause a big challenge to our training programs because there are issues of continuity. Any of you who've been a patient in a teaching hospital know how disconcerting it is to have continual parade of new people coming in who you haven't seen before, but because the shift changed or because the rotation changed, now you've got a whole new team. Well, this is going to add to that. So it's going to create some of those kinds of problems, which we need to take seriously in terms of communication. But my guess is that overall, it's probably a step in the right direction towards a more humane approach to our house staff training. And actually, our chair of surgery, and the surgeons have been some of the ones who I think have been the most resistant to this, our chairman of the Department of Surgery welcomes it. And he says that he thinks that they can actually train surgeons better with that constrained amount of hours because it'll focus their efforts on what do they really need to do during that time. It's an important question.
Robert Benjamin, I'm a City Club member. I'm also an attorney and social worker by training and do conflict management in healthcare systems and teach in that area as well. I'm going to be unfair. You've had very good specific questions that look at time and look at other kinds of accreditation standards. And I would like for you now to go to the other extreme, the abstract level. It seems to me you've made allusions to systems, but in some ways did that in a kind of linear way. What we have, it seems, is a very complex system, the healthcare system, a self-organizing system, complex organizational stuff, and a very linear approach to all of our problem solving, even if we borrow from the aviation industry. There are two pieces that I would like for you to address directly. One is, as you're talking about the complexity of this, I would gather that most patients, people, the general public, lay people, have absolutely no idea what you're talking about. That I don't care how much you practice and you have good intention in terms of communication for disclosure, that you have a very, very serious problem of first educating public to understand the complexity, the Gatwandi complications, the notion of what a doctor goes through. And second is going to be the professionals themselves and changing the resistance which is endemic to the field, a hierarchical structure. What are you doing in those regards to educate the public and educate the specific profession?
Well, we do try through the Ethics Center, especially with regard to the ethical issues themselves, to be open to the public, to speak at forums like this, to be available to answer questions in the media, and to try to do things like creative role-play teaching sessions with people from the community as the simulators, to teach our young doctors to use language people do understand for difficult and sensitive communication. I think the biggest challenge you bring up is that there isn't one system. We've talked a lot about the OHSU system and when you're an inpatient, and the example I described, you stayed within one system. Our biggest communication issues are probably when you move between systems. When you have a sudden event at home and you're hospitalized and the event means that you'll need to be placed in a nursing home for a period of time, and you begin to have different teams in different organizations with different funders and different leaderships and different medical record systems that now face some new privacy regulations in even trying to transfer those records, in how we will communicate with each other across settings, is something we've been extremely concerned about in our work in end-of-life care, knowing that in the final months when people are very intensely ill and moving, how difficult it is to get information across settings, and what challenges we face even with the technologies that we have because they don't interface well, and there are privacy issues in sharing information across them.
Thank you. Speaker, City Club is adjourned.